All right, everybody, welcome and thank you for joining. My name is Ashley Lusick, and I'm a health educator for community health at Atlantic Health System. Today's webinar, Perinatal Mood Disorders, What You Need to Know to Support Yourself and Your Loved Ones, is presented by Janice Rodas, night shift nurse educator, maternity center at Overlook Medical Center, and Ann Lawson, nurse midwife, women's health and midwifery at Summit. Before we begin, I have a few announcements. This webinar is being recorded. All participants are muted. If you have a question, please use the Q&A for questions or the chat for comments. We will try and get through all questions at the end of the presentation. Are you or a loved one interested in smoking cessation? Atlantic Health System offers a free quit smoking program. This program includes an individual assessment, free nicotine replacement products, and 6 weekly group meetings to help you quit and stay smoke-free. There are multiple dates and times available, with groups available in person or virtually. For more information about these groups and other resources, or for additional dates and times, please call 1-844-472-8499, option 3. Finally, before we begin, we'd like everyone to please take a quick poll. Please take a moment to answer the questions you see on your screen. Your answers will be anonymous. I will read the questions aloud as well. Question number 1, what do you think perinatal mood disorders might involve? Feeling sad or down after having a baby, feeling angry or anxious, all of the above, or none of the above? And question number 2, which of the following is not a risk factor of perinatal mood disorders? Hormonal changes, age, family history, fatigue, stress, difficult birth experience. And I'll give that just another moment. Great. Thank you all for your participation. And I am now going to turn things over first to Anne.
Hi, good afternoon, everyone, and welcome to our webinar. I'm going to get started here. Let me see. Not clicking, Ashley.
Sure, 1 second, I'll read to your remote control. Okay, and just click anywhere on your screen.
There we go. Okay, so today we're going to discuss a few of the most common perinatal mood and anxiety disorders, their signs, their symptoms, their onset, and how to get help. We know that perinatal mood and anxiety disorders are actually the most common complication of pregnancy and postpartum. When we think of complications of pregnancy, most people think of preeclampsia or gestational diabetes. And while those are common, about 6 to 8% of women will develop one of those complications. Mood disorders are actually 3 times as common. About 21% of women will have some sort of mood disorder in their pregnancy. So it does make that the most common complication of pregnancy. Perinatal mood disorders are health conditions that can emerge during and or in the first year after pregnancy, and it can affect both women and men, so both the birthing person and their partner. The most common disorders include depression, anxiety, bipolar disorder, postpartum compulsive disorder, and postpartum psychosis. And we'll go through a little bit of each of those in detail. They can affect any birthing person, regardless of their age, their race, their ethnicity, their income, their culture, their education. It doesn't matter what your background is, they can affect anyone. And they're not the result of anything that the birthing person has done or not done. The one thing to keep in mind is that all perinatal mood and anxiety disorders are temporary, they're treatable, and they're blameless. It's nobody's fault or nothing's fault that causes it. There are some factors that put someone at a higher risk category than others. So, if you have a history of a mood disorder while not pregnant, that would put you at a higher risk for developing a mood disorder during pregnancy or post pregnancy. A history of alcohol or substance abuse, life stressors such as work demands, financial stressors. We all have life stressors, so that is unanimous with everyone. But everybody has a different amount of life stressors that they have, financial burdens, etc. Physical and emotional changes related to pregnancy, childbirth, and caring for the newborn. So, someone who has a newborn in the NICU may be at an increased risk than somebody who has a baby that goes home with them on their normal time schedule. Somebody who has a difficult or traumatic birth can be at a higher risk than somebody who had a relatively smooth labor and birth process. And then changes in hormones that occur during and after pregnancy are also a risk factor. So, as I mentioned before, mood disorders are the most common complication of pregnancy. It's estimated that 1 in 7 women or birthing people will experience a mood disorder in the first 3 months postpartum. And if you pull that lens out, it's actually 1 in 5 birthing people will experience a mood disorder in the first year. So if we go beyond the first 3 months, we see that if we follow more people end up developing some sort of mood disturbance in that first year of life. For men, it's about 1 in 10 fathers will experience postpartum depression. If a birthing person experiences a postpartum mood disorder, 50% of their partners. So whether that's a same sex couple or male female couple, if the birthing person experiences a mood disorder, their partner is 50% more likely to experience a mood disorder as well. Feelings can range from mild to moderate to severe. And if symptoms are severe, the birthing person, the baby's health, and well being are all at risk. So these don't just affect the birthing person, mood disorders affect the entire family. So the partner, the child, or children if there's other children involved. Perinatal depression versus baby blues. So, baby blues is a common term used to describe the transient mood changes that happen after giving birth within the first 2 weeks. About 80% of birthing people will experience the baby blues period. This is the result of hormonal shifts, fatigue, feeling emotionally overwhelmed, being thrown into this new world of parenting. It's a big transition. Depending on how much support a person has, depends on how quickly the baby blues resolves and how severe the symptoms of it are. With good self care, so having an opportunity to nap, to shower, to eat, to hydrate, being felt supported, feeling heard, feeling taken care of, those things, the symptoms of baby blues typically resolve within 2 weeks. For postpartum depression, those after that 2 week period, if those symptoms persist and they seem to be getting worse, then that now is a transition from baby blues into postpartum depression. So we see that about a quarter of women or birthing people will experience some sort of depression pre-pregnancy, about 33 to 35% during pregnancy, and then a sharp incline to about 40 to 42% during the postpartum period. So almost double from pre-pregnancy to post-pregnancy. So as I mentioned before, if you have a mood disorder pre-pregnancy, you're significantly more likely to experience a mood disorder postpartum. Most episodes of depression happen within 4 to 8 weeks after the birth of the baby, with the peak being somewhere around 3 months postpartum. So, when experiencing depression, people will often report a few to several of these symptoms nearly every day for at least 2 weeks. So, feeling sad, anxious, empty, feelings of hopelessness, or feeling very pessimistic, being very irritable, quick to anger, frustrated, feeling restless, um, feelings of guilt, worthlessness, helplessness, loss of interest, fatigue, difficulty concentrating, difficulty sleeping. Um, Difficulty sleeping can be insomnia or sleeping too much, having a difficult time waking up with the baby when you need to, which can result in trouble bonding and forming attachment with the baby. And then the most severe thing is thoughts of death, thoughts of self harm, harming the baby, that life may be better without you, that your baby would be better off without you. Those are obviously very serious signs of postpartum depression that if you are experiencing or you see your partner experiencing or a loved one experiencing, do not hesitate to reach out for help. We know that women are at the highest, or birthing people are at the highest risk for suicide 7 to 8 months postpartum. So, most people are being screened for postpartum depression in that 6 week postpartum window when they visit their provider. And then after that, there's really not much interaction with the provider. Um, so 7 to 8 months postpartum, most people have returned back to work. They're trying to juggle working with raising a family, with their responsibilities to themselves, their partner, their child. So 7 to 8 months, people are really not looking out for these symptoms, which is why it's such a dangerous time period. So to be aware that it's not within the first 6 weeks that most people are at most risk. It's really several months later when people are at the highest risk. It's important, like I said, if you are experiencing these symptoms or someone that you know, somebody that you love are experiencing these symptoms, that you contact a healthcare provider right away. With treatment, things will get better. So the biggest misconception is that it will never go away, it will never get better, and that's just not true. Treatment is often a combination of medication and therapy. Oftentimes, medication is needed to stabilize the hormones in our brains, um, help to sleep. Medication can be useful to sleep. When you're not sleeping, everything seems significantly worse. When you're not eating well, when you're not getting some fresh air and sunshine and exercise, and when you're not communicating with your friends and family, when you shut yourself off, everything kind of feels exponentially worse. So, with medication, that allows you to sleep better, to eat better, to have the energy to get out of the house and to interact with family and friends. All of these things then help improve the mood, as well as therapy, talking through what you're experiencing, finding ways to help you cope with things that you may think are not normal, but are actually very normal for parenting. So treatment is available and it does work. If left untreated, we know that babies from a person experiencing a mood disorder will often sense that those feelings from the parent. They'll have more difficulty feeding, more difficulty sleeping. The babies themselves may experience more colic. They may have more developmental challenges. That's from a lack of interaction, from a lack of that bonding with the parent. And then oftentimes, when the parent gets on the other side of their depression, there's often this sense of guilt and this sense of loss for all the months that they were not connecting with their baby, that they were not in tune with their baby. And that then makes them kind of go back into a depression a little bit, once they realize, that there was help, that there was a solution. So really getting ahead of it at the beginning is the best answer to the problem. Postpartum psychosis is a very rare but life-threatening emergency. It usually occurs in the first few days to 6 weeks postpartum. The most common time is in the first 2 weeks postpartum. Postpartum psychosis is not the result of untreated postpartum depression. So if you have postpartum depression and you don't get help, postpartum psychosis is not the result of that. It's something completely different. People with postpartum psychosis experience delusions, hallucinations, mania, paranoia, confusion. They often think that they're hearing a voice telling them to harm their baby, um, to harm themselves. People that are experiencing these symptoms should never be left alone. They should never be left alone with their baby. This is an immediate medical emergency that needs attention right away. Calling 911, going to the nearest emergency room. Under no circumstances should this person be left alone or left alone with the baby. We've all seen these stories on the news of women that have harmed themselves or harmed their baby, or both hurt their baby and then took their own lives. Oftentimes, it's the result of postpartum psychosis. So if you're, with a person that just does not seem at all like themselves, call 911 and do not leave that person alone. Again, a very rare, only about 1% to 2% of people will experience this, but because it is life threatening, it does require emergency medical attention. I'm going to pass it over to Janice now, and she'll talk about some of the other disorders.
Hi, everyone. Thank you for joining us. So I think for those outside of the maternity world, we always you refer to a lot of it as postpartum depression, but there's other things within postpartum mood disorders aside from postpartum depression. Annie just touched on the postpartum psychosis. There's also perinatal anxiety disorders. Um, So those are it's generalized anxiety disorders, must have 3 or more symptoms, excessive anxiety and worry, often about one's health or baby's health, difficulty controlling one's worry, you're ruminating, persistent thoughts, agitation, irritability that can escalate to rage, then spiral to guilt and shame. There is usually a trigger to the thought spiral or symptom onset. Restlessness, inability to sit still, feeling on edge, poor concentration or mind going blank, sleep disturbance. Again, we saw that also with postpartum depression, difficulty falling asleep, staying asleep, or unsatisfying sleep. Increased somatic symptoms, which could be muscle tension, palpitations, racing heartbeat, shortness of breath, and GI distress. Then you also have your panic disorders, must have 4 or more symptoms, episodes of intense fear or discomfort reaching a peak within minutes. You have shortness of breath, chest pain, sensations of choking or smothering, dizziness. You can have hot or cold flashes, trembling heart, rapid heart rate, numbness, or a tingling sensation. Again, restless agitation or irritability, excessive worry or fear, persistent fear of going crazy, losing control, or having a future attack. Often no identifiable trigger to the thought spiral or symptom onset. The 3 greatest fears is for a panic disorder is fear of dying, fear of going crazy, and fear of losing control. Another one of the mood disorders is perinatal obsessive compulsive disorder. So obsessions are defined as recurrent and persistent thoughts, urges, or impulses that are intrusive and unwanted and cause marked anxiety or distress. The individual attempts to ignore or suppress the thoughts, urges, or images, or to neutralize them with some other thought or action. Um, Compulsions are identified as repetitive behaviors that the individual feels driven to perform in response to the obsession. Behaviors or mental acts are aimed at preventing or reducing the anxiety or the distress. So some symptoms, again, of perinatal obsessive compulsive disorder, perinatal OCD, is intrusive, repetitive thoughts, usually of harm coming to the baby. Caught in a spiral of what if thinking, tremendous guilt and shame, horrified by these thoughts, hypervigilance. Mothers engage in behaviors to avoid harm or to minimize triggers. So you'll have sometimes some of the examples could be the birthing parent constantly washing their hands, right? I can't, I can't touch the baby without washing my hands. Then they wash their hands. Did I wash my hands good enough? Okay, I'm gonna wash them again. Maybe I didn't do it right, so I'm gonna wash them again. And it's kind of those, like, they're trying to prevent harm to the baby, but it's those kind of acts that um, can be an example of that. So some common presentations is fear of deliberate harm, contamination, which could be accidental harm. You have also like or ordering or arranging. It could be religious as well, and like checking, like um, it could be anything. Like, did I shut did I shut the oven off? Let me see. Let me go check. Oh wait, I don't know. Maybe did I shut it off? I'm gonna go back and check. So those are some of the examples to that. So exposure and response prevention, ERP, it's a gold standard for treatment for OCD. So just a little bit of background on that. It's a treatment that specifically targets the source of a person's obsession by directly exposing them to it. It's a specialized training is required, and it's part of the International OCD Foundation. Um, So where to get help? Here we have some places that you can get help. The National Maternal Mental Health Hotline. It's free and confidential mental health support. Postpartum Support International. Again, free confidential mental health. They do it in English and Spanish. 988 is a Suicide and Crisis Lifeline. Postpartum Support International also offers free virtual support groups for anything one can be going through. They are a great, great resource. New Jersey Family Healthline, um, and these are the hours and the phone number for that. And those are our references. And just in closing, I think we just want to help bring awareness to perinatal mood and anxiety disorders, help to educate family and friends on what to look for in their loved ones, and we also want to let the birthing population know that you are not alone and that there is help out there. Okay.
Great. Thank you both so much. Great. And at this time, I will also be sharing the post-test poll. I believe that is all we have for today. So I would like to say we appreciate you for joining us today. We kindly ask that you take a few minutes after today's webinar to complete the program survey. The link to the survey has also been added to the chat for your convenience. A special thank you to Janice and Anne for dedicating your time and expertise today. If you have any additional questions or comments, you can send an email to communityhealth@atlantichealth.org or call 1-844-472-8499, option 3. And that concludes today's webinar, and I hope you all have a great day.
Thank you.
Thank you.